so we're delighted to be hosting this event on the lands of the Gadigal people of the Eora Nation here at Royal Prince Alfred Hospital, and acknowledging Aboriginal elders past and present, and paying our respects to any Indigenous people who might be joining us today. We've got a lot of online people joining, but I'll first welcome Professor Anne-Marie Hill. So she's visiting us from the University of Western Australia, and so she's a Senior Principal Research Fellow in the School of Allied Health, and her research is supported by the Royal Perth Hospital Research Foundation, and she has really a focus on improving the health of older people and their wellbeing. And she also holds an NHMRC Emerging Leader Investigator grant, and as well as multiple other grants. And she has a background as a physiotherapist, and like me, she's a fellow of the Australian College of Physiotherapists. So yeah, welcome, Anne-Marie. We'll just do Charlotte's introduction and then we can seamlessly transition. So after Anne-Marie, we're going to hear from Charlotte McLennan, who's a physiotherapist and clinician researcher here in the Sydney Local Health District. She's mainly worked in aged care and rehabilitation, and she's currently managing the Protect Fall Prevention program here in the district, as well as undertaking her PhD, and she's going to be telling us a little bit more about that. But first, just bear with us while we transition some slides. So Lauren, our trusty assistant, will come and do that, and then we'll hand over to Anne-Marie. Welcome.
Thank you everyone for coming today, and particularly it's the end of the day, and so particularly thanks to everyone who's come along, and if you've been clinically working for the day or been at meetings for the day. Thanks for coming, and I'll try to skim through these fairly quickly, and I'm hoping, because it's a rather eclectic mix of a presentation, I'm just hoping to present a few different things that might be of interest to different people, because I know there's a very broad group of people here today. I just check if my slides are going to forward on. Yeah, hopefully they are. Yeah. I will also just like to start with an acknowledgement to country and acknowledge that we're meeting on the lands of the Gadigal people of the Eora Nation, and pay my respects to elders past, present and emerging, and thank any Aboriginal people that might have joined us today, and acknowledge also my reconciliation journey with the artist of the beautiful artwork there, Dr. Margaret Gidger, who I've worked closely with, and acknowledge all Noongar people. I just need to acknowledge my funding support, no matter how big or small it is when I talk, because, obviously without funding, you couldn't do the work that you do. And once you start to acknowledge funding, then I'd like to acknowledge some of my team and just the fantastic people. And whenever someone gets up to give a talk of any kind, it's all the people that work back at the offices with me there. Some of them there who have brought the information to you today. And because we've just been awarded it, I'd really like to acknowledge the MRFF team with the new grant we've got on hospital falls prevention. Because it's the work of all these people that has led us to some of the work that I'm talking about today. So fantastic to work together with those people. So I'll just give a tiny bit of context, because this is something I think you will all know, but I do think that it's really important for us to hone in on this for younger graduates, people who mightn't be so aware, and particularly our students. That people age 65 plus form 17% of the population. but they form nearly half of all admissions. So I think it's really important for all our new graduates to realise that they are working in a field where it's going to be very important to have expertise in aged care. Otherwise, we run that risk that when they come to the ward, they think, oh, well, I've just, got one frail older person, but actually that's the population that's who they're going to have. The other reason that I think it's really important we bring up the topic is because it's so easy when we work in counting falls per 1,000 bed days to forget people, and we all know those people. We've all had at least one experience, but probably some of us many more. And, I think there's the actual fall and the injuries and the deaths, and there's all this ripples of distress. And this is a carer that we interviewed earlier this year, whose mother fell over in hospital a couple of times. And you, I think, can pick up the distress that she's feeling there, where she was so angry and upset about the fact that her mother fell over and cracked her head, and her mother got into trouble. And you can see her quote there, they were more scolding. My mum had her fallen, and she's describing the damage, and she says, and they were just more angry with her. They were like, why didn't you wait? And this was her frail older mother with dementia. And, you can feel the upset there, can't you? And you think, gosh, we really can't stop. We have to keep doing something better. That's not me making that beeping noise, just to let you know. I think they're on mute, but we'll hope that anyway, just to let you know, it's not me. So I'm just going to present a tiny snippet of evidence to just backdrop a little bit of my talk. And I think, again, you'll be the sort of audience that you'll know all about the new World Falls Guidelines. And I'm also just talking a little bit about the systematic review that I helped Meg Morris with as part of a partnership grant. So we had a large partnership grant where she was CIA and I was CIB, and for our new grant, I'm CIA and she's CIB, and we're taking on the work on hospital falls prevention, which is really exciting. So some of the evidence in the World Falls Guidelines comes from Australian trials, and I think that's, high quality evidence, which is really good. Should I just go back one? So I'll just bring up some of that evidence, which is from trials that I've been an intimate part of, and one that I led. Which shows that tailored patient education, so providing patients with an individualised message to them, reduces falls. And we did this as a first trial led by Terry Haynes, and the second trial that I led implemented that as an extension of the trial, where we involved nurses and gave nurses education about the education and how to support patients. So, that trial was effective. And since I was a person who, as a physio, delivered that education in the first trial and saw the really good effect it had, it led me to a strong conviction of patients, why it's so important. Because I had so many patients say, "Oh my gosh, nobody ever told me that." And I had an old Italian man run down the ward after me who had fallen and broken his ankle from being in hospital. And as I went away, he was limping down the ward with his crutches going, "You should tell more people this," and he was just so enthused, and so overwhelmingly find that a lot of older people are very keen to hear this sort of message. And then in our systematic review, I'm sorry, I keep double clicking energetically. In our systematic review, we've also, when we looked at all the evidence, we meta-analysed the evidence for non-person interventions. So, things like bed alarms, low load beds, wearable sensors, and we didn't find that those have an effect. And that's where I tend to say to people, well, I'm not saying you have to do patient education the exact way we did it in our trial, but what I am saying is talking to patients in some way about falls and stuff seems to work. Putting bed alarms on doesn't. So I'm leaving it with you to say, pick what, you know, at present, this is what we know works. So it seems better to do something that we have evidence of than something that now systematic reviews show doesn't work. And when you look at that with the kind of concurring study, a study done by a fantastic early career person, Hazel Heng, you know, Hazel did a scoping review of 43 articles, looking at only trials that used education as an intervention. And what we found in that scoping review was that trials that used education reduced falls, not always in randomised circumstances, improved knowledge and self-perception, and empowered patients. And concurrently, you know, when you look at those, you know, those two sort of opposite sides of evidence, we've recently had a very high quality cluster step wedge trial run in Perth, so in my own state, and Adelaide, using wearable sensor vests, and that was a really well run trial and showed no effect in reducing falls rates. So, you know, again, I myself thought, well, perhaps this will work because rather than bed alarms, the alarm's on the person. It went to, they especially altered the wards and put IT up such that the sensors alerted nurses through their call bell system and through the nurse's personal alarm. And yet that really made no difference at all on falls rates. So I think, you know, it just suggests to me again, let's go with the patient option because that seems to be what's good. So just looking at falls very quickly, you know, we know that falls happen when patients are by themselves. It's one of the biggest arguments actually for patient education because falls happen when people think something and they're by themselves. So at that point, no matter how experienced a physio or nurse you are, you can't help them. You're not there. So you need to rely on them having the certain environment or something that's going to make them think about what to do or something that's going to change what they plan to do. We know that falls occur early. They don't always occur early in one place. When the patient gets transferred from an acute to a subacute or subacute to rehab, they occur early in that next place. So they occur when the patient moves into some new place. Most of them occur in the bed and the bathroom, so we just know that they occur and they relate to toileting. Remember that the biggest history or predictor of falls is if the patient has had a fall. So as soon as the patient falls, why don't automatically lots and lots of alarm bells ring? Because to many of our new graduate staff, that isn't an alarm bell. To me, that's an enormous alarm bell. To our new graduates, it isn't an alarm bell. I was telling Charlotte this morning that my daughter-in-law is studying nursing. She's in her second year, and so she's recently bought a textbook which comes in 2 volumes. She's very conscientious and she's bought the hard copy of the textbook. And it's more into the now, instead of the year 1 was the physiology and anatomy, and year 2 is started to move into, you know, the textbook's called something like practices of nursing, something like that. When I looked in the index of the 2 volumes, each volume being, you know, there must be about 800 pages in each volume, there's 2 or 3 mentions of aging. It's barely mentioned. So there's nothing our undergraduates are learning about caring for older people that is in this her core nursing textbook. Also of interest in the textbook, unless I've missed it, and believe me, I'm fairly pedantic and have looked through, they mention the word physiotherapist once. So they mention the concept of multidisciplinary teams is vaguely mentioned in the textbook. There's one comment about a physiotherapist. So, you know, I'm not saying that physios don't also receive a somewhat siloed education, but it indicates why some of our teams don't have these automatic alarms. And also just want to bring up to you that we know that from the large survey done in the UK, that 80% of hip fractures in their hospitals happened on a first fall. So we really can't afford to feel comfortable and think, well, you know, people fall and, you know, sometimes they fall and we can't do anything about it. Have to convince our wards and our teams that we need to stop all falls. We need to stop the first falls. We need to stop harm from falls, because unfortunately, falls happen the first time a person falls over can be the time they seriously injure themselves. Doesn't mean we can prevent all falls, but it does mean we can ensure that we're making every effort to improve our falls prevention. And so just bringing together, you know, that cascade of events. We know that falls in hospitals are due to that, the patient, the environment, and the staff actions and decisions that can all either lead to preventing or resulting in a fall. So, you know, why is patient education important? Well, aside from my own personal knowledge and evidence about patient education, it's important enough that the Australian Commission has made it a standard. So I think that's, you know, we're not expecting them to make just anything a standard, are we? So they're actually mandating and saying, well, when we come out and we're going to do our equip on you as a hospital, we're expecting that you will tell us how you're addressing this standard. So it's important. But as I say, I think it's important because of that very upset carer that I spoke to earlier this year, who was heartbroken her mother fell, heartbroken her mother was treated so disrespectfully, and completely mystified about, well, why did she fall over and how come she's in trouble and what's all that about? So, you know, I think that you know, that's why it's so important, isn't it? So I'm just going to talk about a couple of things. I want to mention very briefly that we've revised our patient education program. I'm really just alerting you to our study that we've just published recently. And what we did was remake our video booklet, and we've just been doing some work on translation. So that's really what we hope to look at with our MRFF grant, and building up how we implement that kind of program, which is really patient education, but it's not really just about patients. It's about staff and educating staff at the same time, and leading, you know, that kind of ward level quality improvement across the board. So it's just really to alert you to that. And that's some of our results there. We co-designed the new program with older people, and you know, we just wanted to get their feedback and make sure that everything was right. And we've done some further little edits and co-design work since then. So that's some of what I'm talking about. So I'll just talk to you a little bit about the consumer feedback that we've got to hopefully link into where I think we can continue to improve, either personally when you're talking to patients, or when you're implementing quality improvement across your wards and you're going to be looking at what you're doing. So we interviewed older patients, and we actually made sure we had 47 people in this study, and we asked people to come and join focus groups or interviews who had been in hospital before, either once or more times. So we had a range of people. Some were in their 80s, some in their 70s, some in their 60s, and some have been in hospital multiple times, some once or twice. And we specifically wanted to talk to them out in the community where they live, where they didn't feel there was any need to think about being polite, or because we know from even like there's a very large consumer study being done in the UK by the Consumer Ombudsman, which found that older people are incredibly not willing to complain about their healthcare. Even when they have received extremely poor healthcare, they still don't want to complain. So we wanted to talk to these older people way away from the hospital, where they wouldn't feel, oh, I don't want to say something and get that physio into trouble. We wanted them to feel really free. So when we asked them about falls, it was quite hilarious in a way, because when you just said, well, you know, what did people tell you about falls prevention in hospital? What did people tell you about it? You know, did they tell you, we had to kick properly? And they just went, nothing. I don't know what you mean, but no, nobody told us anything. And this was, and even the people that fell said, yes, the fall was the first notion I had that actually I was at risk of falling. And so this was a real classic quote. You know, I didn't see anything about falls. Nobody spoke to me about falling. So I wasn't aware that it was an issue. That was a very common finding, very common theme. We asked people about their experiences, and, you know, this was another carer who said, well, their parent, you know, they got very, very wobbly, and their story was, you know, there was never really anybody there to help her. So I think she probably was at risk of falling, and she, you know, they went on to talk about she did nearly fall a few times. And this was another patient who'd had surgery and said, you know, I stumbled a few times. I had a lot of tubes, lots of bottles. You know, navigating those things was a bit tricky, but there was nobody to help me. You had to do it on your own. That was another strong theme of our patients, saying, well, I did feel actually pretty wobbly, but there wasn't really anybody to ask. You just, you know, you just sort of had to get to the toilet, had to do it. So that was another message from people. We also, of course, asked people, you know, well, thinking about your risk of falls and that you know, that concept of being aware of falls. And they were very insightful. Our consumers were very insightful and said, well, you know, I can see why me or other older people might fall over, because, you know, we're just basing it on what we're like normally. So, you know, we think we're tougher than we are. After being in hospital, you think, well, you're just fine. And someone commented that the nurse asked them, were they okay? And they just said, sure, I'm okay to do it on my own, because they thought to themselves, well, I guess I am, so I probably am. You know, they didn't have a concept of what things were about. We particularly asked people about information about falls and about information in general about mobility. And we had a couple of people told us they received some good information, and that there was just a couple, and they were good examples. Like this person who said, you know, I was told by the physio I was at risk for falling, and this person went on to say the physio was really good, really clear. They told them about what to do on the ward, what mobility they should have. So that was a kind of an unusual comment, but that was one or two comments. But most people said things like, well, they said if there was an issue, make sure you ring the bell and just wait. They weren't sure what that meant. And quite a few of our patients commented in Western Australia, we have a system where a lot of times there's whiteboards and journey boards near bedsides. And some of our carers and patients commented that, you know, there's a whiteboard in the ward and the nursing staff is supposed to write on it who's looking after you and comments, but it never got used. Nobody paid any attention to it. So, you know, our patients were aware that, you know, maybe that would be good, but nobody seems to use it. The other thing that our patients were very shocked and surprised about was when we did show them our little video, and when I told them a bit about the research for the second half of the focus group, I said, well, now I want to tell you a bit about falls, and showed them the video. And this was a very classic response, you know, where one person said, well, I've learned more today from you than I've learned in hospital and through my doctor. You know, so people said, oh my gosh, we never knew that falls was an issue in problem. And, you know, some of them suggested that we should take the video, you remember these are consumers, we should take the video and show it to all GPs. And the GP should tell all older people about this hitherto unknown problem about falls in hospitals. You know, they were very enthused and very, you know, definitive that they should be alerted. They, you know, a couple of them were quite, hey, hang on, you know, someone should be telling me about this. So we obviously also asked them about, well, you know, we know falls are an issue, and they looked at the video. The video said, wait, you know, the video said you should call the nurse for help. And they all went, oh no, You can't do that because the nurses are too busy. They're busy doing important things like giving out medicine and looking after sick people. Going to the toilet is not a priority. And, you know, that was a very strong thing. You know, people say that nurses are very busy. You can't expect them to come and help you go to the toilet. Like, you have to do that yourself. So they were very aware of that concept of you don't interrupt the nurses. When we asked people about their experiences, the other thing they commented on that they thought affected the ability of getting knowledge was ageism. And they said, you know, people don't, the sort of concept was, they said people don't tell you these things because they think you're old and you won't know anything, you know. So this was someone said, you get put into that older person category. And, you know, it's almost like you get to a certain age and you've got conditions and then it's all over Red Rover, you know. So, you know, patients felt that, I think actually some of our consumers thought that it was just because they were old, and I somewhat empathetically felt like saying to them, no, it's just that a lot of times health professionals don't tell any patients the right information. It's not just because you're old. But, you know, they felt like that was a reason why people didn't bother to tell them anything. So we asked them, of course, then about how can we do it better? You know, what can we do? We wanted to deliver education better. And they thought, well, when you're really sick, you won't be able to deal with it. And they said, well, it's not, if it's not relevant, I wouldn't pay attention. So, you know, I need somebody to explain to me how it's relevant. And then, of course, the big strong thing came up of, well, I'm too embarrassed to ask for help. I don't want to ask for help to go to the toilet because that would be embarrassing. And the concept of staff being too busy came up again, and the ageist attitude, you know, that was a real barrier to them trying to talk to staff about what they should be doing and about how they could get education. And so then when they talked about enablers, though, they said a lot of our consumers talked about that an allied health person could come and give some information to people because they were really aware of nurses being really busy on the wards. And they said it would be great if it was shared. And they said it would be really good if the doctor gave you the same information, because the doctor seems to tell you something completely different and it's very confusing. And then they commented a lot to us because we obviously showed them our booklet and then little leaflets, and they said, oh, you know, it can't just be on the shelf. You have to have somebody personalise it for us, and it needs to be interactive. And I'm just skimming through this a little bit, but I thought I'd like to just tell you a little bit about this. Hopefully I'll just skim through these last bits. So, you know, I think that it's really important. Reviews, there's been 2 big reviews lately, and they mostly contain large numbers of studies that I've done in the reviews. And they really demonstrate that older people consistently underestimate their risk of falls. And if you're going to implement education on a ward, you need to raise patients' awareness, and actions need to be really concrete for patients so they understand clearly, really simply and clearly. And you need to, I think we need to get the message out to all staff that our older patients, because our study is in concurrence with other studies, it's not a novelty what we've found. Patients feel deterred from asking for any help. And yet let's just remember that most actions on a ward that are required for safety depend on patients engaging in the required action. Because remember, if the patient doesn't ring the bell, you won't go and help them. You can't, even if you do intentional ward rounding, you can't walk around like a policeman constantly. You have to do your nursing task or your physio task at some point. So you rely on the patient to actually follow through, and they can't follow through if they don't know what they should follow through about. How are you going to do that? I think that's the thing. The first thing, most important thing for all our patients, and we found this in earlier, larger studies, is this is a different study. I'm just presenting a snippet of it, our World Cafe study, where we had a large number of older people. And we actually asked these people straight out, look, we're health professionals. We want you to tell us, how should we tell you about falls prevention? What's the most important thing? Because we want to get the message through. And they said the most important thing is that you have people are positive and they give us respect and they care about us and have some time to listen. So that was what they said is the most important thing. How can we get this through to our new graduate allied health and nursing staff, that what our patients, older patients, are looking for is someone who says, hi there, are you okay? How are you? Are you okay? It's just so important, isn't it, that we don't rush in and say to people, have you taken your medicines? Let me do your blood pressure. Here's the bell, goodbye. We have to somehow build that image with our patients. Let's give this time to shift. And just remembering, what's our patient's context? Oopsie days. Remember that whenever a patient comes into hospital, their prior experience of the situation and their thoughts and feelings, their levels of stress, that's what impacts on the patient. And that's why you need to do that critical thinking every time you talk to a patient. So you have to ask the patient, hey, have you been in hospital before? Have you been in this ward before? Think about fundamental safety. Whenever we go to a lecture, what are the two things that are said all the time? The first thing said is, thank you for coming to this talk today. If there's an accident, Kathy will wear the red hat and tell us to go out there. And the second thing is the ladies is there and the toilets are over there. Yeah, it's fundamental that whenever a patient moves to any ward or comes into any hospital, that the first person says is hello. If anything is wrong, ring this bell at any time for anything. Secondly, the toilet you'll be using is just there. Now, do you need to go at this very minute? Can I get you a bottle if it's a person who can't move? Those are the two things that they're so crucial, aren't they? They're so critical. And yet how often do patients sit and not hear those two statements? So I'm just going to finish off by saying, remember that all your patients are adults, and adults learn when there's a perceived need. That's you and I have come here today because we want to learn about falls. If we want to give patients education, the education needs to be individualised. It needs to be visible to the whole ward, so we give the same message. It really needs to be so positive and encouraging. It needs to be so clear and simple to the patient, and it needs to be coordinated. And I should finish, but I'll give you one quick story before I go. So essentially, I'm just going to say one of the things that education does is it works well with comprehensive care in such a good way, because it systematically assesses all patients for their cognitive ability. It assists patients to work to a mobility plan, because if you say to the patient, you're allowed to get up out of bed, you quickly find out if they actually don't want to get up out of bed. So it works to that. It helps you get your patient to contribute to environmental alerts, so the patient can feel confident to step up and say, oh, excuse me, I need my frame. It helps the conversation with patients and their family about the structure of recovery. Well, the first day we'll do everything for you. Now, this second day, I want you to set the goal of walking a little bit with me. It helps. It provides a patient-centered approach. But that consistent message across wards is so important, thanking our consumers. And I'll just tell you one last story. I had a lady in one of our focus groups who had bilateral hip replacements, and she was recounting her experience of staff being fairly negative, and she said, I had a nurse who she shifted ward, and the nurse came in and told her very angrily, in her respect, she felt the nurse was angry. The nurse may not have been, but she felt it. And she said, the nurse said, you need to do more for yourself now. You should get up and go to the toilet yourself. Don't be ringing the bell. You're quite capable, and go yourself. So she felt very anxious, and she thought, obviously people think I'm lazy here. So the next time she got up, she went to the toilet. She actually felt quite proud of herself. She'd gone to the toilet. She came out of the toilet. As she came out of the toilet, another nurse came into the room and said, what are you doing out of bed? Do not go to the toilet by yourself. That is the wrong thing to do, and you must wait for help. You have not been assessed on this ward as moving around. So, of course, that was productive of great mirth around the focus group table. But, yeah, that's a constant issue. I, the physio, say, do more. As the nurse say, wait there for me. So we have to get our messages straight and give people a consistent, simple message that they can follow. So thank you, everyone. And Charlotte, I'm sorry.
Fantastic. Thanks so much, Anne-Marie. Such valuable messages. Don't go away, because you're going to ask
slides.
Oh, wait, you are going to do the next slides. Anyone? So just to repeat the question, we've actually got 46 people online, which is awesome. So the question was about patient education for people who are very sick or confused. And actually there was an online question about cognitive impairment as well. So come over to the microphone.
Yes, so really important point. And I've removed a fair few slides talking about some of the subtleties of that. Firstly, people with mild cognitive impairment, we should give them education, even more simplified, make sure they understand the one or two very basic messages, make sure we've left the environment set up such that if they need cues, that it's ready. For people who are a little more cognitively impaired, it's important that we engage their family straight away. And also it's important that we set the same goals for people with cognitive impairment, and that staff are the people who action the goals. So if I, as a physio, go in to provide the person with their routine education, and I meet that patient, look at their notes and realise they've got dementia, I'll still set the same goals. For that patient, the goals will be they will walk regularly to the bathroom with their aide and one person assistant, but I need to clearly document that goal, and I need to tell the nursing staff, here's this goal for this patient. However, we can't rely on that patient to ring the bell. So that person will not be ringing the bell. Well, they may do, but I don't expect them to. So the goal will be that we will now drop-down menu, address the toileting plan. Now, what's this person's toileting history? How can we make sure? So we will still set goals for these people. Other reason that I think it's really important to have a daily check as the nurse on the board doing the care for that person is to look at the patient goals for that day or the patient plans, and have a quick chat with the patient, because that will tell you if the patient's becoming delirious. We know that about 50% of falls, first falls, happen when people have started to get delirious and nobody's picked up on it. So if you've already given education, you're then more likely, if you come in and say to the patient, so you're going to be using your frame, and they appear not to be able to talk back to you, teach back about the goal, you've got the opportunity to go, hey, how are you feeling, and look into whether they're getting delirium. But we do think that it's very important to engage carers. And even though our consumers tell us that their families are busy, but they concurrently tell us their families need to know. So they say, my family members are very busy, but they still should know this information. So, and we've also had feedback from our consumers who said, I haven't presented to you our staff focus groups results today, but our staff were more inclined to see it as a black white, like, well, if the patient's really acutely ill, I can't tell them something. But our consumers were a lot more motivated and strong about, hey, if I'm really sick, okay, I can't listen to anything. but I really need someone to tell me before I do get up. And, our consumers were quite strong in saying, the nurse needs to see, if I'm starting to get a bit better, that's when I need the person then to come and give me the leaflet and tell me. So they're expecting a high standard from us, and I think we need to try and get to it.
Fantastic. Thanks, Anne-Marie. We might leave it there, so we've got time to hear from Charlotte, but we'll have a bit more time afterwards to join us for a snack and a drink and some further informal conversation. So yeah, over to Charlotte now.
Great, thanks, Kathy. And we're on the home stretch. I echo Anne-Marie's thanks for attending it late in the day after busy days. I'm going to provide a brief overview of a talk I've called Designing an Acute Hospital Fall Prevention Program, which is going to talk about some of the work we've done here in Sydney Local Health District to inform an acute hospital fall prevention program we're excited to be rolling out later in the year. So I'm going to give a very brief overview of the studies and the findings that have informed this program. But if anyone wants to know more, please absolutely reach out. I'd love to talk more about it. So as a very brief background, in Sydney Local Health District in late 2022, a new fall prevention and management strategy was released. It was evidence-based and, in line and informed by a lot of Anne-Marie's amazing work over the years, and really did focus on education and multifactorial approaches, but keeping in mind that a lot of the strong evidence for that is in subacute settings. So we wanted to be mindful of that. And importantly, the strategy really allows the intervention flexibility and tailoring, which we see as increasingly important. So as many of us know, though, it's all well and good to have a strategy, but how do we actually get that implemented or embedded within care? And, how do we do that with fall prevention initiatives more broadly? And luckily, there's an ever-growing body of healthcare implementation literature. So, going to that, informed us of the need for careful planning in our program, which is where these studies have come in. So I'm going to go through 3 studies here and then briefly over our Protect Fall Prevention program. So the first study we undertook was what's called an intervention component analysis. And I'm not going to go into the methods because that could be an hour on its own, but essentially it's a fairly novel literature review process that looks to provide really practical insights into why, what about interventions make them more successful or otherwise in randomized controlled trials. And it uses both a qualitative analysis combined with an effectiveness synthesis. So we looked at 32 randomized controlled trials of hospital fall prevention interventions. And essentially, so here they were a mix of both acute and subacute settings and mixed settings, and there was a broad range of intervention types as defined by Profane, which categorises fall prevention interventions. What we saw come out of the thematic analysis of all of these papers was 3 main themes that appeared to be associated with successful interventions. And sorry, my numbers have gone a bit funny there, but the first was that the interventions were really integrated with the local intervention setting. So this could be that ward staff were delivering the interventions, or there was a more systems approach and, real engagement with hospital level management into both designing and rolling out the interventions. Interventions that were responsive to patients' risks, but also their needs and abilities, and had an ability to be tailored to that, but also tailored to broader population characteristics appeared more successful. And finally, patient and family involvement in the fall prevention interventions. And sometimes this was lower level, simple advice that you are at risk of falling in hospital. And at other times it was a greater role where patients were really empowered to have an active role in preventing themselves from falling when in hospital. We then looked for these themes. We had a definition for all of these themes and looked for their presence in the intervention description notes of all these trials to work out, well, are they actually present in the most successful trials? And in doing that, what really came out as the 2 things that really seemed to be present in our effective fall prevention trials were interventions that were responsive and had an ability to be tailored to both patient and population needs, and that had patient and family involvement. So they were 2 sort of really key takeaways for us. The next study we did was a qualitative study with staff and patients from 2 large hospitals that looked at what are the considerations when implementing fall prevention programs in the acute hospital setting. So you can see here we had 50 participants whose transcripts were written up, coded and analysed. And again, we had 3 major themes come out, each with sub-themes. So the first issue we saw, which there is a lot of correlation with Anne-Marie's findings here, which just strengthens, you know, the focus we need in this space. The first was that fall prevention is a priority, but just not mine. So we really did hear from staff across the board and from a lot of patients that they felt that, you know, falls in hospital needs to be addressed. It's an important issue. It's a challenging one. Someone needs to do something about it, as that sub-theme shows. But then what came up as the undercurrent issue was, well, whose job actually is it? Who is going to prioritise, you know, implementing fall prevention and addressing hospital fall prevention? So we heard a lot of disciplines talking about other disciplines' roles and the importance, you know, of it. It was sort of that pass the buck. And you know, patients often felt like, well, they didn't necessarily have the power to really be actively involved in hospital fall prevention, whereas, you know, staff, as well as talking about other disciplines, did often want to talk about patients' roles. And overarching that too was this challenge of competing priorities in really busy acute hospital settings. And so, you know, needing to prioritise fall prevention, but, you know, stating that it's often not actually prioritised. So the next theme really captured a sense of frustration and complexity and overwhelm with hospital fall prevention, which we termed nothing seems to work. So we heard both staff and patients feel overwhelmed by the complex nature of the acute hospital setting and trying to implement fall prevention within that. Pressure cooker practice captured a lot of workforce pressure, you know, staffing shortages, staffing turnovers, new staff and you know, interdisciplinary disconnect, which again Anne-Marie has flagged. And then the final part of this was what we coined best practice meets the pecking order, where we did see evidence of hierarchical tensions, you know, between frontline and management staff, and also between patients and staff. So unfortunately, we really, you know, patients really came across as sort of at that bottom of that hierarchy. They often felt they didn't want to ask for help. They didn't want to be a burden. You know, they didn't want to get in the way. They didn't want to speak up. And so, you know, that was really evident again in line with some of what Anne-Marie found. It was not all doom and gloom though. So we did have a real sense of optimism around shared responsibility being a solution for implementing hospital fall prevention programs. And so there were 2 main ways that it was identified that this could be done, and that was through connecting across the care team, so having greater multidisciplinary roles at buy-in and, you know, prioritisation of fall prevention, and also really importantly partnering with patients and families, but balancing this with understanding that, you know, being in the acute hospital setting is a really overwhelming time for patients and their families, so we really need to be mindful about how we go about that. Racing through the third study, we are still collecting follow-up data for, so I'm just going to flag it very quickly, but it's a feasibility study where we looked at implementing the quality improvement based falls prevention strategy with you know, a slightly supported implementation in the acute hospital setting. And this was largely to inform the development of the intervention and implementation of a larger program. So designing that program, as the title of the study says. So what has occurred with that is 4 acute hospital wards have nominated a team within their ward, ideally multidisciplinary, but not always, to be guided in their implementation of the fall prevention strategy. They've received some support through education from people with expertise in hospital fall prevention and through quality improvement coaching. Some staff did have the opportunity to go to a quality improvement training course for 2 days, but not all. And we've looked at routinely collected hospital data, baseline and follow-up staff surveys, and are collecting qualitative information as well as data. So the early takeaways from this program that, you know, are really informing our next program is the power of understanding local data to inform necessary tailored change. So it's been really well received. The wards that we work with have been really positive and open to the chance to really learn how to use their local data and, you know, investigate it and sort of hash it out to work out, well, what do I need to focus on? What do we need to focus on our ward to create change? There are challenges around engaging multidisciplinary teams and to, you know, overcome this, really ensuring clear and relevant roles within the ward teams and that the goals that the ward team are working towards on do feel relevant to all disciplines that are involved in that leadership team. The coaching feedback is that it really needs to be structured, so set in the diary weekly, encourage accountability, so, you know, really, you know, not too hands-off. There does need to be that bit of support and support that ward leadership team to implement change more broadly across their ward. The final thing is, you know, we found we really had learned from balancing frontline ownership, but also having some expert direction. So if it's led too much, you know, that it's weighted too heavily on frontline ownership, it risks straying from being effective enough to target preventing falls. So balancing that, is what we've been learning a lot around. So ultimately, this has informed our Protect Falls Prevention program, which we're really fortunate to have received NHMRC partnership grant funding to implement and evaluate the program. So Protect is for prevention through education and coaching, and it will see wards receive supported implementation of coaching and other tailored strategies to implement tailored fall prevention interventions, which are guided by the local health district fall prevention strategy. So, you know, it's a revised version of the feasibility study. Wards will create a multidisciplinary Protect team and then submit an EOI to participate in the program. The wards will then work with their coach and fall prevention experts on a needs analysis, looking at local incident data and patient and staff surveys around fall prevention to work out, well, you know, what specific interventions and implementation strategies does our ward need to try to make change in this space. The ward leadership team will have the opportunity to attend a 2-day quality improvement training course that will be specific to hospital fall prevention, so with some additional education within it. And then they'll receive 16 weeks of quality coaching and access to fall prevention expertise from multiple disciplines to help guide them in implementing the interventions and changes that come out as being necessary from their needs analysis. It will be evaluated in a stepped wedge type 1 hybrid effectiveness implementation trial, which I'm not going to go into too much detail because it's late in the day, but for those interested, we can speak more about it, and that's a quick snapshot of the design, with our primary objective being evaluating the impact of the supported implementation of the ward-based interventions on the rate of falls per 1,000 bed days. And then we'll have a suite of secondary outcomes around effectiveness, implementation and cost effectiveness. So very final overarching considerations, I didn't sort of want to just leave it there, is that, you know, what we've really learnt along the way so far is really the importance of assessing and addressing the readiness of buy-in of patients and multidisciplinary staff at all levels of an organisation when implementing hospital fall prevention, harnessing the hope and positive influence of shared responsibility and enhanced communication, as well as patient and family involvement and appropriately, and absolutely avoiding one-size-fits-all approaches to hospital fall prevention. So big thank you. These are some of the people involved. There's a lot more. It's absolutely a team and multidisciplinary team effort here. So yeah, watch this space for more Protect information, and thank you for the opportunity and thank you for staying late in the day.